Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 373 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The first case reads, TAC, a 62-year-old woman, is brought to the hospital by family members because she has become increasingly lethargic and unresponsive during the past several days. Approximately 4 years ago she underwent a radical mastectomy and node dissection followed by radiation and chemotherapy for breast carcinoma. Despite several courses of chemotherapy, she developed metastasis to the bone. About 1 week before this admission, TAC complained of fatigue, muscle weakness, and anorexia. Since then, she has spent most of her time in bed and has had very limited oral intake. Medications taken before admission included hydrochlorothiazide, oral morphine sulfate, and tamoxifen. Physical examination reveals a dehydrated, cachectic woman responsive only to painful stimuli. Her vital signs include the following: a blood pressure of 100 systolic, 60 diastolic and respiratory rate of 16 breaths per minute. Pertinent laboratory values are as follows: sodium levels of 138 milliequivalents per liter. Potassium levels of 4.5 milliequivalents per liter. Chloride levels of 99 milliequivalents per liter. A bicarbonate of 33 milliequivalents per liter. A BUN of 40 mg per deciliter. Creatinine of 1.2 mg per deciliter. Calcium levels of 19 mg per deciliter. Phosphate levels of 4.5 mg per deciliter. Albumin levels of 3.0 grams per deciliter. The ECG revealed a shortened QT interval. What are the common causes of hypercalcemia? Which of these might be responsible for the hypercalcemia seen in TAC? Let's now look at malignancy. Malignancy and primary hyperparathyroidism are the most common causes of hypercalcemia. Hematologic malignancies, such as multiple myeloma, tend to be responsible for more hypercalcemia than are solid tumors. Cancer of the breast, lung, head and neck, and renal cell carcinoma are solid tumors commonly associated with hypercalcemia. Malignancy can cause paraneoplastic hypercalcemia secondary to bone metastasis, which results in increased bone resorption. Alternatively, patients may exhibit hypercalcemia in the absence of bone metastasis owing to the production of osteolytic humoral factors by the tumor. The mediators secreted may be parathyroid hormone-like substances, prostaglandins, cytokines, transforming growth factor alpha, and tumor necrosis factor. Let's now talk about hyperparathyroidism. Hyperparathyroidism is the other common cause of hypercalcemia. Although the etiology of primary hyperparathyroidism is unclear, women tend to experience the condition more frequently, especially in the 4th to 6th decades of life. Approximately 75% of patients have a single adenoma, whereas much smaller percentages of patients have multiglandular disease, hyperplasia, or carcinoma. Other conditions that can result in hypercalcemia include post-kidney transplantation, immobilization, vitamin A intoxication, hyperthyroidism, Addison disease, and pheochromocytoma. Hypercalcemia can also occur secondary to increased intestinal calcium absorption because of vitamin D intoxication, sarcoidosis, and other granulomatous diseases. Use of thiazide diuretics, lithium, estrogens, and tamoxifen, as well as excessive calcium ingestion together with alkali, that is milk alkali syndrome, may result in hypercalcemia. TACs, breast cancer, bone metastasis, volume contraction, and use of hydrochlorothiazide and tamoxifen may all contribute to her hypercalcemia. My next question to you reads, how is hypercalcemia manifested in TAC? The clinical presentations of hypercalcemia vary substantially among patients, but the severity of the symptoms correlates well with free calcium concentrations. The specific presentation depends on the rate of serum calcium concentration elevation, the presence of malignancy, the parathyroid hormone concentration, and the patient's age. Concurrent electrolyte and metabolic abnormalities and underlying diseases will also have an effect. Because calcium is an important regulator of many cellular functions, hypercalcemia can produce abnormalities in the neurologic, cardiovascular, pulmonary, renal, GI, and musculoskeletal systems. As seen in TAC, the signs and symptoms can be nonspecific: fatigue, muscle weakness, anorexia, thirst, polyuria, dehydration, and a shortened QT interval on the ECG. The effect of hypercalcemia on the central nervous system includes lethargy, somnolence, confusion, headache, seizures, cerebellar ataxia, altered personality, acute psychosis, depression, and memory impairment. The neuromuscular manifestations include weakness, myalgia, hyperreflexia or areflexia, and arthralgia. Symptoms of impaired renal function include polyuria, nocturia, and polydipsia. These may reflect a defective concentrating ability, possibly because of resistance to the effects of antidiuretic hormone. The glomerular filtration rate may be decreased because of afferent arteriolar vasoconstriction, and if hypercalcemia is prolonged, nephrolithiasis, nephrocalcinosis, chronic interstitial nephritis, and renal tubular acidosis may be present. Hypermagnesiuria and metabolic alkalosis may also be observed. Calcium has a positive inotropic effect and reduces heart rate, similar to cardiac glycosides. ECG changes indicative of slow conduction, with prolonged PR and QRS intervals and shortened QT intervals, are commonly seen. In severe hypercalcemia, increased QT intervals, widened T waves, and arrhythmia may be present. The gastrointestinal symptoms of hypercalcemia are related primarily to the depressive action of calcium on smooth muscle and nerve conduction. Constipation, anorexia, nausea, and vomiting result from reduced gastrointestinal motility and delayed gastric emptying. Duodenal ulcer can occur because of increased acid and gastrin secretion. Pancreatitis can occur during acute hypocalcemia owing to the blockade of the pancreatic ducts caused by intraductal calcium deposits. Proteolytic enzymes may also be activated by calcium to cause tissue damage. Both ulcer disease and pancreatitis are more common in hypocalcemia associated with primary hyperparathyroidism. They are less likely to be seen in patients with malignancy-induced hypocalcemia. After vigorous fluid resuscitation with IV saline, combined saline and furosemide diuresis was instituted in TAC. Her serum calcium concentration declined very slowly, prompting the use of calcitonin. Despite initial success, the serum calcium concentration rose to pre-treatment values within 24 hours. Higher dosages of calcitonin could have been attempted at this point. However, pamidronate was used instead. Her serum calcium concentration finally stabilized at 8 mg per deciliter after several days of therapy. What was the rationale for each of these regimens? What other agents are available for hypercalcemia treatment? Several therapeutic approaches are used to lower serum calcium concentration, increasing urinary calcium excretion, inhibiting release of calcium from bone, reducing intestinal calcium absorption, and enhancing calcium complex formation with chelating agents. The underlying disease that causes the hypercalcemia should also be treated, if possible. The specific treatment used depends on the serum ionized calcium concentration, the presenting signs and symptoms, and the severity and duration of hypercalcemia. Immediate therapy was needed for TAC, who had symptoms consistent with severe hypercalcemia. Specific interventions are described in the subsequent paragraphs, but as an overview, hydration and diuresis with furosemide generally are the first steps in the acute treatment of hypercalcemia. If these measures fail to reduce the serum calcium concentration adequately, several other agents can be added. Calcitonin provides a rapid onset of hypercalcemic effect, but its duration of action is relatively short. Thus, a bisphosphonate could be used to elicit a longer hypercalcemic response. Gallium nitrate is an alternative, but it is not commonly used. Other agents, such as inorganic phosphates, glucocorticoids, and prostaglandin inhibitors, also have been used to treat hypercalcemia with varying success. Next we will discuss hydration and diuresis. As noted, the first-line emergency treatment for hypercalcemia is hydration and volume expansion. Most patients with hypercalcemia are volume depleted because of the accompanying polyuria, nausea, and vomiting. Normal saline 1 to 2 liters is commonly given to correct the fluid deficit and to expand extracellular volume, which will increase urinary calcium excretion by increasing the GFR and inhibiting calcium reabsorption in the proximal tubule. Because both sodium and calcium are reabsorbed at the same site in the proximal tubule, saline hydration will reduce the reabsorption of both cations simultaneously. TAC was hypotensive and appeared dehydrated. Therefore, saline hydration was used initially to treat the hypercalcemia. In patients who have renal failure or heart failure, saline hydration and forced diuresis should be avoided. After adequate volume repletion has been established, IV furosemide can be administered to augment calciuresis. Furosemide blocks the reabsorption of sodium, chloride, and calcium at the thick ascending limb of Henle's loop. Doses of 80 to 100 mg every 2 to 4 hours can be used until a sufficient decline of the serum calcium concentration is attained. Smaller doses, that is 20 to 40 mg, commonly are given to avoid the significant loss of fluid and electrolytes caused by the more aggressive regimen. Adequate amounts of sodium, potassium, magnesium, and fluid should be used to replace any therapy-induced electrolyte abnormalities. Fluid balance as well as serum and urine concentrations of these electrolytes must be monitored closely. Urine flow must be maintained and the renal loss of sodium chloride must be replaced to preserve the calciuric effect of furosemide. In TAC, the decline of serum calcium concentration was slow, possibly because of inadequate restoration of plasma volume, replacement of renal sodium loss, or both. More aggressive hydration with adequate sodium replacement ensures that the efficacy of furosemide is not compromised. Next we will discuss calcitonin. Calcitonin can be used when saline hydration and furosemide diuresis fail to lower serum calcium concentration adequately or when their use is contraindicated. Calcitonin reduces serum calcium concentration by inhibiting osteoclastic bone resorption. It may also increase the renal excretion of calcium and phosphorus. Only the salmon-derived calcitonin product is available in the United States. The serum calcium concentration is often reduced several hours after calcitonin is administered, and the response may last approximately 6 to 8 hours. The drug is relatively non-toxic compared with organic phosphates and may be used in patients with dehydration, heart failure, or renal failure. Nausea, vomiting, diarrhea, and facial flushing are the more common side effects. Soreness and inflammation at the injection site may also be seen. Because of the potential for developing a hypersensitivity reaction to salmon calcitonin, the manufacturer recommends skin testing with 1 international unit of the salmon calcitonin before the first dose. As seen in TAC, tolerance to the hypercalcemic effect of calcitonin can develop after 24 to 72 hours of therapy. This escape phenomenon may be secondary to the altered responsiveness of the hormone receptors, and might be prevented by concurrent use of corticosteroids. After long-term therapy, antibodies may develop as well. The dosage of salmon calcitonin is 4 international units per kilogram given subcutaneously or intramuscularly every 12 hours. The maximal dosage is 8 international units per kilogram every 6 hours. The hypercalcemic response is often limited, and serum calcium concentration seldom drops to the normal range. And now let's look at bisphosphonates. Bisphosphonates are synthetic analogues of pyrophosphate that form stable bonds that are resistant to phosphatase degradation during osteoclast-mediated bone mineralization and resorption. The compounds adsorb to the hydroxyapatite crystals of the bone, inhibiting their growth and dissolution. In addition, the compounds may have a direct effect on osteoclasts. The 2 distinct pharmacologic classes of bisphosphonates that exist have different mechanisms of action. Etidronate, which does not contain any nitrogen atom, is metabolized to cytotoxic, non-hydrolyzable ATP analogues. In contrast, nitrogen-containing bisphosphonates, such as pamidronate and zoledronic acid, inhibit the prenylation of proteins and have potent inhibitory effects on osteoclast-mediated bone resorption. In addition, they induce apoptosis of osteoclasts as well as certain tumor cells. Further anti-tumor activities may be mediated through their inhibitory effect on angiogenesis, stimulation of the gamma T cell fraction in blood, and reduction of cancer cells' adherence to bone matrix. At present, etidronate, pamidronate, and zoledronic acid are approved in the United States for the treatment of hypercalcemia secondary to malignancy. Let's now briefly look at etidronate. Etidronate is administered in doses of 7.5 mg per kilogram for 3 consecutive days by IV infusion over the course of 2 to 4 hours. Response may be seen after 1 to 2 days, and normocalcemia is expected to be attained in most patients, with response sustained for greater than 10 days. Because of the inconvenient dosing schedule as well as variability in its duration of action, other bisphosphonates are now preferred for the treatment of hypercalcemia of malignancy. In addition, etidronate may inhibit bone mineralization, a property not shared by other bisphosphonates. Next we will look at pamidronate. Pamidronate is more potent than etidronate as an inhibitor of bone resorption, but it has negligible effect on bone mineralization. For moderate hypercalcemia, albumin-corrected serum calcium concentration of 12.0 to 13.5 mg per deciliter, a single dose of 60 to 90 mg of pamidronate is commonly infused over the course of 3 to 4 hours. For severe hypercalcemia, albumin-corrected serum calcium concentration greater than 13.5 mg per deciliter, the dose is 90 mg. The advantages of pamidronate are that it requires only a single dose and produces a superior response compared with 3 doses of etidronate. If the hypercalcemia recurs, the etidronate or the pamidronate regimen may be repeated after an interval of greater than or equal to 7 days. Etidronate, dosed at 20 mg per kilogram per day by mouth, may be given to prolong the normocalcemic duration, but nausea and vomiting are common with the oral therapy. Long-term treatment may result in osteomalacia. However, the limited life expectancy of most patients may diminish the significance of this adverse effect. Etidronate use has resulted in renal failure, which probably is caused by the formation of bisphosphonate calcium complexes in the serum. Because pamidronate requires a lower molar concentration to produce a comparable hypercalcemic effect, it is less likely to impair renal function. In fact, pamidronate has been given to a limited number of patients with end-stage renal disease without adverse consequence. And now we will look at zoledronic acid. Among the bisphosphonates approved for the treatment of hypercalcemia of malignancy, zoledronic acid has the most potent effect on bone resorption. It is superior to pamidronate with respect to the number of complete responses, time needed to attain calcium normalization, and duration of effect. Because 8 mg doses are not superior to 4 mg dose, 4 mg doses are administered IV over the course of 15 minutes. The drug is well tolerated at 4 mg doses. Zoledronic acid's superior efficacy and convenience of administration make it the preferred bisphosphonate for hypercalcemia of malignancy. Emerging studies show that zoledronic acid may also have promising effects in reducing skeletal complications secondary to bone metastasis associated with breast cancer, prostate cancer, non-small cell lung cancer, and multiple myeloma. Now we will discuss gallium nitrate. Gallium is a naturally occurring group 3A heavy metal. In addition to its anti-tumor activity and potential for use as a chemotherapeutic agent, it has been shown to be effective in the treatment of moderate to severe hypercalcemia of malignancy. Hypercalcemia is induced primarily via the inhibition of bone resorption and reduction in urinary calcium excretion. Several clinical studies have shown the effectiveness of gallium nitrate in the treatment of cancer-related hypercalcemia when compared with agents such as calcitonin and bisphosphonates. The recommended dose is 100 to 200 mg per meter squared per day as a 24-hour continuous infusion for 5 days. Vigorous hydration is necessary to prevent nephrotoxicity. In general, its clinical use is limited by the inconvenient method of administration, significant risk of nephrotoxicity, and cost. Next we will look at phosphate. Inorganic phosphates lower the serum calcium concentration by inhibiting bone resorption. They also promote the deposition of calcium salts in the bone and soft tissue. If given orally, phosphate reduces intestinal calcium absorption by forming a poorly soluble complex in the bowel lumen and also by decreasing the formation of active vitamin D through enzyme inhibition. When given IV, phosphate is very effective, but renal failure and extensive extraskeletal calcifications are a concern. For these reasons, IV phosphate is not the agent of choice for acute treatment of hypercalcemia. Oral phosphate, that is 1 to 3 grams per day in divided doses, may be used for long-term maintenance therapy, with the optimal dose determined by serum calcium concentrations. Nausea, vomiting, and diarrhea are common problems, especially when the daily dose exceeds 2 grams. Soft tissue calcification is also a concern, and hyperphosphatemia and hypercalcemia can occur if the dose is not titrated appropriately. Phosphate therapy should not be given to patients with hyperphosphatemia or renal failure because it can cause further deterioration of renal function. Accumulation of the potassium and sodium salts in phosphate preparations may also present a therapeutic problem in certain patients. Next we will discuss corticosteroids. Several possible mechanisms exist that may explain the hypercalcemic effect of corticosteroids. Vitamin D3-mediated intestinal calcium absorption may be impaired and the action of osteoclast activating factor, which mediates bone resorption in malignancy, may be inhibited. Corticosteroids may also have a direct cytolytic effect on tumor cells and inhibit the synthesis of prostaglandins. Prednisone in daily doses of 60 to 80 mg is given initially, with subsequent dosage reduction based on the calcemic response. Alternatively, hydrocortisone, dosed at 5 mg per kilogram per day for 2 to 3 days, may be given. The hypercalcemic effect will not be apparent for at least 1 to 2 days. Patients with hematologic malignancies and lymphomas tend to have a better response than those with solid tumors. Corticosteroids are also effective in treating hypercalcemia associated with vitamin D intoxication, sarcoidosis, and other granulomatous conditions. They are not generally used for long-term therapy because of their potential for serious adverse reactions. Let's now take a closer look at prostaglandin inhibitors. Because prostaglandins of the E series, especially PGE2, may be responsible for hypercalcemia associated with some malignancies, non-steroidal anti-inflammatory drugs may be useful for a select group of patients with hypercalcemia. For example, indomethacin is effective in lowering the serum calcium concentration in patients with renal cell carcinoma but not in patients with other types of malignancy. Indomethacin, 75 to 150 mg per day, can be tried in patients unresponsive to other therapy, especially when it is used as part of palliative treatment for cancer pain. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 374.